If you have a patient who has both cataracts and Fuchs, and they need a transplant and cataract surgery, you can combine them.
We're going to watch this awesome case of a DMEK. It's an endothelial keratoplasty, a transplant to replace the patient's diseased tissue, endothelial tissue, and replace it with new donor tissue.
DMEK stands for Descemet's membrane endothelial keratoplasty. There's also DSEK. We just want to make sure you know the abbreviations. Here, a Rogowsinski hook, little tiny hook, is used to score, meaning from the back of the cornea, score Descemet's, which is the basement membrane of the endothelium, and the endothelium to remove both.
It looks like incredibly thin tissue just watching this, and that endothelial cell layer is just one cell layer thick, and that's the endothelium that's pumping fluid out of our cornea. When it doesn't work well, we see that cornea swells up with fluid, and patients sometimes have a reduction in vision or glare or other symptoms.
And even Fuchs themselves causes a change in the basement membrane, which can also cause a decrease in quality. This again is right side and left side to get a 360-degree score of that Descemet's membrane, and then pulling it in to make sure it's actually separated and connected.
Now what we're going to watch is, of course, is a combined DMEK and cataract surgery. Do these have to be combined at the same time? Could they be done separately? And are there some pros and cons to doing it the way that we're seeing in this video, where it's going to be combined?
So there's a little stripper taking it off, making sure not to injure the stroma, so there's no scarring. But combining them basically decreases the surgeries. It's only one surgeries as opposed to two. Two surgeries done at the same time, but only one visit to the operating room, only once the risk of infection. And separating them leads to some more predictable outcomes in the cataract surgery because the cornea changes, meaning it changes the prescription. And then the cataract, again, is based on the measurements before the corneal transplant. Sometimes combining, which we've done before, light adjustable lens plus the DMEK kind of bypasses this whole problem. But if you do DMEK first, then cataract, then you might damage the transplant that you just put in.
And now we're transitioning into the actual cataract portion of the surgery. This is the same patient, same day, same surgery. The first portion is the capsulorhexis, where that first layer of the capsule is just being peeled away, and that's going to provide an opening to the actual lens where the rest of the work is going to be performed.
You get an Akahoshi-Prechoff, so two instruments that manually split up the lens, and then the chopper is used as a horizontal chop to break up the lens into smaller pieces that then allows me to remove them. Obviously, as you can tell, everything's sped up.
When I think of a chop, I'm thinking of an axe chopping, but that looked more like a tool that, to me, it looked like it was separating from the inside out. Was that a valid?
Very valid point. I tried to not use the term chop, even though I just did, because it's the official term. I think tearing, separating, splitting might be a better term.
Splitting that wood there. This part is the phacoemulsification unit, which is just breaking apart those small fragments and pulling them out of the lens, trying to clear out all of the inside of that lens capsule. Sometimes it's referred to as the bag, and that's where the new lens will be placed, and we'll see that shortly here.
And here again, polishing the irrigation aspiration handpiece, polishing the posterior capsule, all those little folds that you see on the posterior capsule, making sure it's not torn. And then after replacing with viscoelastic, a lens goes in. This specific lens is a BVI B3 PC, also made by Hoya. The reason why I like this lens in a DMEK, it's a stiffer lens, meaning it's less likely to move in the front of the capsule during the manipulation that you'll see in a little bit.
I was going to ask about that with this particular lens, and we'll get back to that in a moment. This is the actual injector loaded with the new donor tissue, just the endothelial tissue stained in blue dye so it can be visualized. And there it was. If you blink, you're going to miss it, and now it is in the anterior chamber.
And because it is so thin, the most dangerous part is what I just did, removing the injector, because then the transplant can obviously follow back out, so immediately close it with one suture. That suture is removed at 1 week, and it's just extra safety so the lens, that transplant doesn't come out while I'm manipulating it, as you see now. You also see right now it's called a double scroll formation. This is just trying to get it in the correct orientation, and then it's unfolded with, named after a person, again, a Urich tap technique. The little red spots that you see on the bottom is I make iridotomies at the time of the surgery to decrease the chance of pupillary block, because you'll see a big gas bubble put in at the end.
I'm trying to understand how that donor tissue is actually scrolled. Is it scrolled up this way or backwards?
So it depends. If it's how I want it to right now, it's scrolled this way, meaning that the scrolls come from the back to the front, because the endothelium is always on the outside of the scrolls. And you see a little mark placed in the top left there that shows where the orientation, here's a little orientation mark, a little notch that you can follow later, but it tells you just that I'm still, there we go, I'm pointing it out, that the correct orientation is maintained, and this stays there forever. There's a little bubble that locks the graft against the cornea, and then I place more reinflate the anterior chamber, the bubble gets smaller as the pressure increases, and then I can move that transplant exactly where I want it to be.
How long do you expect that bubble to stay in the patient's eye after surgery?
About 5 days, probably by 1 week. So a lot of times 20%, this is SF6, which is a gas that stays in the eye longer. I use 16.6% SF6 because it tends to go away more quickly and decreases or pretty much eliminates the risk of posterior synechia forming between the iris and the lens, because if the gas bubble stays in there long term, it pushes the iris posteriorly.
So at this point, we have the graft unscrolled. It's at the back of the cornea. There's an air bubble, and that flicking motion, is that just trying to get it to completely unroll and get
Moves
centered?
it. I don't know if you saw previously the position of the graft. This kind of just moves it down a little bit, and at the end I place more steroids, and the now gas bubble covers the graft completely, and it stays against the cornea. And as the pumps start working, they will stick themselves up against that cornea.
Beautiful.